Hello there. I thought I would bring a video to you guys about what to look for in patients, for the typical patients that we can help. If you're waiting on somebody telling you they have foot pain in order to either help them out with a foot orthotic or to refer them along to one of our podorthist partner, you are missing out on 95% of the people you could potentially help. So what I wanted to do is give you a few tricks on what to look for in order to facilitate the introduction of the podorthic treatment with peak orthotics. So when you see a patient, there's obviously the multiple things that a rehab orthotic can do that you're aware of already, in terms of aligning the rear foot properly, and align which makes the tibia rotate to an ideal position for the knee to swing over top of it, which creates a more even muscle balancing, reducing your pressure on the knees, the hips, lower back, etc., etc. So all of this. But what I want to show you is a little trick to give your patients a feel for what you're trying to achieve. So with Lana here, we've got on her right foot is obviously a pretty bad case of hallux valgus. But now we want to test, first of all, for the mobility of the foot, and to how much does the subtalar actually move, and can we quickly readjust the subtalar joint's position in order to achieve a more neutral position to give Lana a feel. So what we're going to do here is I'm going to get you to put most of the weight on the right foot, and then I'm going to get you to bring this foot forward a little bit like the position that we do for the casting. So now, by keeping most of the weight on the back foot, what we're going to do is just kind of move forward here a little bit. So what you want to do is just kind of put your fingers underneath the calcaneal shelf and the navicular. Just leave your heel on the ground, please. Yeah, so just about like this. And then with this, using your right hand, you can rotate the tibia along here just to activate the subtalar joint, to see if we can put it to inversion, and we can put it back into eversion, pronation, supination, right? So we want to align it so we got a nice neutral position, and I'm going to get you to put a little bit more weight on the left foot. There we go. So with this here, you can see how much mobility, first of all, you've got in the subtalar, and you can see how easily it adjusts, right? So here's the one thing you can give your patients a feel for the position that you're trying to achieve for them. Another quick trick is, if you want to face the fireplace, please, Lana. So what you're going to do is just lift up your heels for a second. And what I do is I put both hands, I oppose them, and I just put support towards the calcaneal shelf to the navicular, and then just go right ahead and put some weight. There you go, and then flex forward and then into a squat. All right, so you feel where your knees are going, and then just stand up for me, and then lift up again, and just allow my fingers to go out, and heels down, and then flex forward. Do you feel the difference? Mm-hmm. What do you feel?
I feel unsupported.
Do you feel like your knees are rolling inwards easier? Yeah. Right? So then if I just put my fingers back in and then put some weight right on it, you see how I'm doing this? I'm actually just putting my fingers underneath the calcaneal shelf and putting a little bit of support to the navicular, right? So then you can give your patients a feel for what it feels like, really, to have a rehab orthotic underneath their foot. If you are to go look for something to see if a patient, in some cases it's kind of hard to see. They still have a decent arch. Their legs are a little bit more externally rotated, But a quick way to see it is you don't have to write on your patient's feet to see this, but for the purpose of this example, I'll do it for you. So what we want to do is right where the Achilles tendon meets the calcaneus, right where it goes into, the tip of the triangle, right? And then just above the fat pad, you can see the edges of the bone, and you're gonna put a little dot and a little dot on the edge. So we've got our triangles. So what we're looking for is a vertical calcaneal stance in somebody that would stand neutrally at mid stance, right? So this would look like from the back as if the triangle is pretty evenly sloped on each side. So now the more that the patient pronates, especially in this foot, the more vertical you're going to be on this axis right here. So I don't know how easy that is to see on the camera angle, but the more everted the calcaneal stance, the more vertical the inside edge will be. And you don't have to write on your patient's feet to be able to see this, but we can see in Lana's case that the right foot is quite a bit more everted in the calcaneal stance than the left foot. Okay, another point I wanted to show you is if you have a patient that their case is not as evident, they might be complaining about a knee or a hip or something else, but I just want to give you some quick clues as to why or what to look for to see if a rehab foot orthotic treatment and a pedorthic treatment would be appropriate for this patient. So in my case, let's use me as an example. You might look at my feet and be like, oh, it still have, it's obviously pes planus. There's not that much arch there, but it's not evidently that overpronated. But if you look at me from the back, and we're going to talk about this calcaneal stance again. If I was to be standing straight, my stance would be looking like this from the back, and then I can squat right over top, right? But in my case, I might be coming to you with a patellar tracking problem, but which is caused by a little bit of overpronation in the subtalar, and my body compensates by externally rotating. So it doesn't look that bad. I still have somewhat of an arch. However, if you put my toes pointing straight again, and you make me flex forward at this stance, I'm naturally gonna end up in a knock-knee position. So it's important that you realize that people that stand a little bit in a duck stance, a little bit externally rotated, that comes from a compensation from either a restriction of dorsiflexion in the ankle joint, which is not my case, but a little hypermobility in the subtalar, and the body just compensates by stabilizing itself by going duck stance. So if you are to put me in this position, I'm naturally pronating, right? So it's important to realize that this little bit of external rotation actually has a lot to do with the muscle balancing of my whole leg, right? Which in this case makes it so I have a weak VMO and medial quad compartment, and my IT bands are trying to compensate by pulling it out, which causes my knee pain. So very important for a guy like me to be, walking straight and actually supporting the rear foot and working on my flexor strength. So now I can build on my medial quad and my glutes to actually be balanced. So hopefully that made sense, and that helps you to just do some quick pinpoints as to who we're looking for and who we can help. in terms of our specialty to work with the dynamic rehab orthotics. So thanks for watching, and see you next time.